We pick up the conversations of the day here in Morning at NTV as we journey on the 12th of March 2026. Our Kickstarter is upon us, diagnosing Uganda's health sector. I am Priscilla Regina Naroga. Welcome. Now, health sector here in Uganda is once again under intense scrutiny, from government reforms to growing resilience from medical professionals. At the center of today's bet are a series of policy shifts that are fundamentally reshaping how we do see the country training doctors, managing health workers and delivering services to millions of patients across the country. The government having announced that medical students will now be graduating after 6 years, completing their internship first before receiving their degrees. A move that authorities say will strengthen clinical competence as well as accountability in the profession. But that proposal is sparking a strong resistance from the medical associations, who argue that it blurs the line between academic certification and professional licensing and also risks disrupting the already strained internship system. At the same time, you do have the Ministry of Health that has unveiled a new health service delivery standards and client charter for 2025 to 2030. And this is promising to improve accountability, clear patient rights, and also better quality care across public health facilities. As if that's not yet enough, the reforms come amid deeper systemic concerns, where you do have government warning that absenteeism and low productivity among the health workers will attract dismissal, describing the problem as one of the undermining situations for service delivery, despite the heavy investment in recruiting and salaries. So for critics, the issue goes beyond discipline, pointing instead to chronic staff shortages. You do have overstretched hospitals, funding gaps, as well as structural challenges in Uganda's healthcare system. So we want to unpack the bigger question: are these reforms the cure of Uganda's health needs, or are they treating symptoms while deeper problems do continue to persist right under our noses? Joining me, we do have the Ministry of Health. We also do have Uganda Medical Association, and we do also have a health practitioner that are going to be giving us perspectives and what are the realities and where do all these actually come from. What are they trying to remedy at the end of the day? To my immediate left, I do have Mr. Emmanuel Ainebiona, who's the spokesperson for the Ministry of Health. You're most welcome.
Thank you. Good morning, viewers, and happy 20 years to the Nation Media Group.
Thank you very much. Now, you do have Ainebiona representing the government's position on health sector policy and communication. He's also been involved in the public engagement around health reforms, service delivery standards, as well as the government's accountability measures in the sector. Now, we also do have, to my extreme left, Dr. Frank Asimwe, President for the Uganda Medical Association. Dr. Frank, you're most welcome.
Thank you. Good morning, viewers. It's a pleasure to be here and to discuss this huge topic.
Okay, and he's well positioned as the leader of the professional body representing doctors across the country. The association having been very vocal on issues including medical training reforms, working conditions, internship policies, and of course the broader health sector governance. And we do have Dr. Shamim Nambassa, who is also a health systems practitioner. Good morning to you, Doctor.
Thank you. Good morning, Priscilla, and good morning to everyone that is watching.
Happy Women's Month.
Thank you. Happy Women's Month.
First of all, what does it feel like to be a woman in the medical field at such a time as this?
Well, thank you so much. I'm a pharmacist by profession, and I've been practicing, I think I can say, 2 years. So, and being a woman in this particular space, we are still dealing with stereotypes. I've on several occasions interacted with people that thought women can't be doctors, women have to be nurses, and up to today I still have to correct some of them that, you know, being a doctor is irrespective of your gender or whatever. So even with such stereotypes, we still find them being hard to deal with, that, you know, some of them feel a woman is not good enough to attend to them. But then also I must appreciate that there has been some shift, and there are people that are starting to embrace women in these particular spaces.
Okay, all right. Dr. Nambassa bringing a pharmaceutical and clinical perspective to the discussion, offering insights into medication access or medication access, patient safety, but also the regulatory systems and how policy decisions are affecting frontline healthcare service delivery. So to open up the scene for the day on our discussion this morning, morning. Uganda's health sector is definitely undergoing a wave of reforms, from training doctors to enforcing accountability among health workers. But before we speak into the debate of the day, let's begin with the broader questions. And I'm going to start with the spokesperson for the ministry here. Is Uganda's health sector actually facing a place of governance crisis, or could it be a workforce crisis, or is it simply growing pains of a system that has tried to reform itself ever and again?
Thank you very much. The choice of words is no crisis. The ministry continues to ensure that it solves the existing challenges that are faced by the healthcare system, which is a growing healthcare system, better compared to a number of years ago. I can say our mandate as a Ministry of Health is policy formulation, ensuring guidelines, mobilizing resources, and in developing these policies, we want to ensure that there is better coordination, linkages with other key sector players, and that is largely what we're here to offer. And I don't think there is any crisis, as you have deliberately tried to frame it.
Okay, all right. Dr. Frank?
Well, thank you very much. Uganda has made bounds and leaps to improve the health sector. Many indicators have come down significantly. Maternal mortality rate really down. Life expectancy up 68 years in a very short time. HIV rates, for instance, prevalence very down. Very many things have improved. I'm passionate about human resource for health. We have the numbers. There are many things which have improved. I think we are dealing with our ability or our fitting in the shoes of dealing with success. That can be a problem. We are succeeding, winning bigly, like Mr. Trump likes saying, but that in itself, if it's not handled well, we can end up bottling it like my team Arsenal often does it. You fail to just nail it, drop the ball in the goal, and that can be a problem.
Mm-hmm. Okay, all right, Shamim.
Well, I think I'll beg to differ from what I hear, because speaking from positions of privilege, I think most times tends to blind what people see. Because if I sat here and I said that the Ministry of Health or the health sector is not in a crisis, I would not be representing the true Ugandan that is actually at the bottom end of receiving the services. So for me, I still do agree, and I believe that there is a very big crisis, right from funding of the particular ministry, and it's unfortunate that I would have expected the spokesperson to at least raise that maybe then we can see government coming through to increase the funding for this ministry, because even when they increased to about 8.1%, we still agree that it is not enough. And that could possibly explain why we still have the staffing gaps that we have, with over 72%. If we are looking at even the healthcare facilities themselves, we have seen districts that do not have a mere hospital. So it's unfortunate, and I think we need to address issues as they are, not to try and sugarcoat what it is that is there. So the Ministry of Health and the health sector in Uganda right now, we can still say that it is in a crisis, and it is actually sick itself and needs urgent solutions.
Okay. Speaking of some of the things that are in need of the ministry's voice, the 6-year medical training reform that the government has considered through the Ministry of Health to produce more competent doctors is the backbone of it. But critics are saying fundamentally it's altering the professionals' training structures. What problem exactly is being treated here with this reform? What are you trying to solve at the bottom of it?
I don't know why we have zeroed it on internship. This is a national education and training for health policy, which is meant to streamline a number of things to ensure that there is a workforce that is professionally trained, highly ethical, and that ensures safety. So and if you've been following these issues, there have been long-standing challenges, having institutions churning out numbers that are unregulated, the standards in terms of the standards, what, for instance, must you possess to qualify to be a medical doctor, to be a pharmacist like my colleague here. And all these have been streamlined, and this is a joint framework that is being implemented by both the Ministry of Health and the Ministry of Education, such that we are able to, for instance, train to train based on the needs of the country, because there has been an aspect of planning. How many numbers are we taking in at entry level, and how many eventually graduate to feed into the numbers we need to supply to our health facilities. So this national education and training policy is meant to ensure that there is alignment, better coordination among the key stakeholders, the health profession, the health training institutions, health professional councils, such that clear roles are defined, and also to ensure that really we have numbers that we actually need to attend to the health needs.
Okay. What other elements are contributing to the national training and education reforms?
There are a number of elements, as I said. Medical internship is among them, ensuring that all our products that come out are highly qualified and are able to ensure patient safety, and ensure that because licensure is a requirement, medical internship is a requirement for licensure and registration, so such that we have all clearly aligned processes and very linked to each other, and that's what this policy is solving for all the health professionals, be it dentistry, be it midwifery, across all board. Mm-hmm. Yes. Okay.
Dr. Frank, the Uganda Medical Association has come out to reject this policy. One of the reasons is that it confuses medical training with professional licensing. Could you broaden our minds towards that?
Okay, thank you very much, Priscilla. First of all, I don't know how this thing was coined or developed. True, I've been president for only 3 months, so maybe I was not in a position to be consulted. But I was also vice president for 2 years. And before that, I was president for the Association of Surgeons for 2 years. And before that, I was again a chair welfare for another 2 years. And before that, I was chair ethics and professionalism for another 2 years. So since 2017, I've been in the leadership of the medical profession. Maybe this was brought before 2017. But I've been a consultant in Mlago since 2012. So who has been consulted? Why don't you have the policy with us now as we discuss it? So one of the problems that we have is that this policy has been prepared in a way that has not widely consulted. However, the evidence is now obvious. A medical intern is not a student. And that's the line which is being marred. And I would straight away say that most likely it's because they are dodging bearing the financial responsibilities. Let me quickly speak to that. Give me a minute to speak to that. Mm-hmm. When we are talking about quality in training, actually internship soothes over any gaps that may have developed during the medical training. It even is more now that we have got 14 training sites. You must have a good internship, granted. But how do you achieve that? Who is an intern? An intern should have graduated and bears a title of a doctor. That already prescribes the level of responsibility they are going to be accorded. They must be licensed for the doctors with the Uganda Medical Practitioners Council. That means when you bring this intern to me as a supervisor, I've practiced medicine for the last 30 years. The first year was an intern. Thereafter, I have been supervising interns. The medical degree is actually a 4-in-1. Bachelor of Medicine and Bachelor of Surgery, Bachelors of Education. We are teachers by training. Bachelors of Administration. So you become administrator, you become a teacher without having to go to that school. So when you bring a person who has been graduated and is called a doctor, they have a title, and they have been licensed, I can now take them as a surgeon to theatre and show them how to operate and then leave them to operate because they are licensed, because they have a title. But if you bring me someone who has not been graduated, you don't know whether they will pass or they will not pass. They are medical students. And someone who is not licensed by anyone, I cannot give him any responsibility. And therefore the training which is supposed to be in internship, which is an apprenticeship, cannot take place effectively. I give you a quick example as I conclude this segment. When you go to the driving school, they must give you a provisional driving license. That means you are going to sit in the driver's seat. Even if you have an instructor by your side telling you accelerate, put an indicator, but you are taking a degree of responsibility. If you are not licensed, if you are not graduated, if we don't know whether the university will fail you or pass you, I cannot give you responsibility. When I did my internship in 1996, at the end of my internship, I had done 800 operations. Of those, probably 750, I had done them on my own. But that's because I had a title doctor. My senior, my supervisor could, at one point in the beginning, you take them to theatre, they work with you. Next step, you work with them. Third step, you remain in the room. Next step, you don't have to be in the room. Can you do that with a student who you don't know whether they will pass or not?
Even
who is not licensed?
Patient, I can't. Yeah.
So that now speaks to what informed that. Who did you consult in designing that policy, which you are hiding from us? I don't see it. So I don't even know what is there. Maybe after this they're going to sneak whatever I'm saying into the policy and sneak and bring it out. So it is dead on arrival. It's a non-starter.
You talked about it being one of the ways the government is trying to dodge paying in medical interns. First, elaborate on that part.
Thank you very much. You see, again, since 2017, I'll take the clock back. Uganda, we are very fertile. We have very many children. I have produced 6 of my own. So I'm part of that. Guilty as charged. The training, primary school, secondary school has been liberalized. So people are studying. Thank God. We thank the government. Medical schools have proliferated. Thank God. When I entered medical school in 1991, there was only 2 universities. Now there are 14. But my friends at the Ministry of Health did not see it coming. And then they're saying, oh my God, there are too many. Too many. Did you not see them coming? Is there no coordination between those who license the universities, those who supervise the admissions? If one university is admitting 600 students, should we not celebrate? Should we wait until graduation 5 years down the road and appear in shock? So from 2017, when they were shocked that now, instead of having 300 interns, now we have 800, they could not pay them. I was paid in 1996. I was appointed from Ministry of Public Service with a salary scale, with a title that I am a medical officer on probation. But because they didn't have money, because they had not prepared, they were shocked. So all these innuendos is to take away the responsibility of who pays. That's why they're saying whoever paid for you at medical school should continue paying for you, and now this 6th year of internship should be part of studies. How?
Just to still have a better understanding of that, the 6th year, if that it's then integrated into the academic studies, then who approves that they can now do the job?
Well, maybe I could shed more light, and I wish to say the policy has not been officially communicated, and it will be communicated. And I wish to state that all consultations were made with the predecessors of Dr. Asimwe.
I was vice president.
Yeah, your presidents were part of the deliberations. And we need to be patient for the policy to be formally and officially communicated, and it will be availed to the fraternity. And I wish to state that still provisional licensing will be given. It's just now extending that if someone is coming out to practice and get licensed, they have concluded internship. Like even other professionals do internship, and it is embedded within the training period, and it doesn't change anything. You will still be given a provisional license, a license to enable you do your work. And when you are leaving,
at what point will that provisional license come?
Part of the training, the institutions
when
of
they're
learning,
going in for their internship.
The institutions of learning will be able to provide who is now eligible and working with the professional councils, and this will be mandatory because this is a transition from academic life to professional life, and it is going to be seamless because you will get a provisional license, you will go undertake internship, and you will be licensed, ready to practice without any, because we've been having even those lapses where some are ready for internship, there are no available internship training centers, and now we want to ensure that we know who is ready for internship from across all the universities. Then the internship training centers are waiting for those who have been issued provisional license. They will undertake their internship. After completing their internship, based on attaining all the competencies, because we are now coming out strong to ensure that there are competent products that we are getting out of our institutions of learning, ensure that this internship is supervised at a ratio that is appropriate as prescribed by this policy. But I call upon Dr. Frank to be patient and wait for the formal communication of this policy.
Okay.
Yeah.
Just to have a better understanding of where the position of the ministry is right now, when you say that they will be given provisional licenses to be able to go for the internship,
like it is currently.
Does that still maintain the element that they will be paid as interns?
All those details I might not have currently at hand. As I've told you, it is not yet formally communicated. So at the time of communication, all that detail will be provided. But the internship period is going to be part of the academic period, such that when you're leaving the institution of learning, you're leaving ready to be licensed to start your practice.
Can I chip in a bit? Sorry, my good friend, you are not a doctor, so you don't know the insides of this. UMDPC, which licenses, does not license medical students. So the university must first vomit you, literally, that you have finished. You have satisfied the requirements for the award of a Bachelor's of Medicine and Bachelor's of Surgery, and therefore you carry the title doctor. That's the only time you can be licensed. What's the difference between provisional and true licensure? In medical training, first year, second year, pre-med, preclinical, basic sciences. Third year, junior clerkship. You clerk, but whatever your clerkship is, we call it clerking. Whatever your notes and your examination are not used to treat the patient. They are used for your training. Fourth year, specialties. Fifth year, senior clerkship. All that time, you do not treat. You can examine, but your notes, your opinion is not part of what is used to treat the patient. So, with that background, with the research, the exams you've done, the university says you have satisfied the requirements. But now for you to start asking my sister here, what is your problem? You examine her and you say, okay, in my opinion, it is malaria. And when I say it's malaria, you treat, and my treatment is binding. You need a provisional license. Okay. So to have a provisional license, you must be qualified and graduated. So
later on, we'll come back to ask exactly why the medical sector particularly has to have an independent nature of internship versus what Naviona here has referred to as all the other disciplines have internship embedded within their academic acquisition. Dr. Shamim, from a healthcare perspective, one as a medical practitioner, but two also on the side of patients, how do you see this, how do you receive this?
Well, it's unfortunate because I think the issues of internship, having issues started when we're almost being deployed. If you can remember very well, for our time, we spent almost an entire year waiting for Ministry of Health to actually formally deploy us for internship. I think, and it's important that we understand the background with which the Ministry of Health and whatever they're saying, whether it's education or whoever, is actually pushing for this particular policy. And I do agree 90% it's because the ministry and government is trying to avoid the issue of funding medical interns. Because if you can remember very well, and I want to make it very clear, interns are not students. Because the issue is, even when medical interns are not students, because even when he says that even other professionals, even other courses have internship, it is not an equivalent of the internship that the medical interns actually do. When you look at the training that we have, 5 years. The first 2 years is biomedical. We're in class, theoretical entirely. Then for the other years till graduation, we are having hands-on training, which I think for me could be an equivalent of the internship that they do. But even then, we have what we call COBAs, the community-based education and research, where we are sent out to go to various hospitals and actually practice. And then that can also be an equivalent to the internship that our other comrades are doing, which is maybe a month or 2 months or whatsoever. But then when you look at medical internship has been done after graduation. So it is not even training. For me, I would refer to it as supervised practice. That you are practicing, only that you're being supervised. And the reason is you have had these 5 years, you have been trained, and then this 1 year is for you to be on ward, to be, practicing, but then it is polishing. They're actually just polishing you to make sure that you are now perfect to go and work on people on your own. But the 5 years training that you have had is enough for you to start to practice. Okay. So the issue is, and for me I would want to ask, when you say that now the internship is going to be done before graduation, are you revising the curriculum? Because for me then that seems like a revision of the curriculum. It is as simple as saying that now you're revising from 5 years to 6 years, but you're trying to sugarcoat it. But then also we must admit that licensure is for you to practice, for example, in Uganda. But we have had people that are going to study their 5 years, get their degrees, bachelors awarded, and they will decide to go and practice elsewhere. Where you may find in other countries, the requirements for you to practice there may differ from what is required in Uganda. Okay. So we are finding that that is also an issue. But then also, most importantly, I think for me, it goes back to the fact that government is trying to avoid the issue of funding medical interns. Right. Because, and we must appreciate that medical interns are the ones holding up the health sector in Uganda. They have been working. They're the ones that, on which the health sector is surviving. So to think that they're going to send out these medical interns to go out and work without having that basic funding that they have been getting is rather detrimental. So I would think that it's time for Ministry of Health, instead of trying to, meander around and try to change things, they should actually maybe be looking at how best can they make this internship better with the funding that they're giving out, with the equipment and whatever. So to me, it looks like we are going backwards.
Naviona, and all of this really speaks into how unclear it is, the reforms that are coming through the Ministry of Education regarding the training and education policy that is being revised right now. But in that regard, if internship becomes a part of the university training, because now what I pick is that now there will be it's going to be a precondition for graduation. Okay, yes. But so it will become supervised training, not supervised practice.
It's the way you choose to call it. Internship is still going to be supervised, and it is part now of the training. So that's why this policy is looking at all the health national health education and training for health.
I think training and practicing are two different things. Training is you're actually teaching me and ensuring that I do it exactly how I should be doing it. Practice means that I'm already doing what I'm supposed to be doing. You're just ensuring that I do it to the ethical and medical standards that are existing. Or
I don't know why. These policies that we've been, the current situation has been informed by policy. And now it is just a revision of policy. And it is answering to the needs based on what has been observed, the outputs we've been getting from the various institutions of learning. And that's why now we want to ensure that whoever is churned out, whether you're from University Y, University X, you are at the same level of competence. Not saying that product of University X is better than product of University Y. And at that has been observed over time. When
so in this
yes.
revision, who bears the responsibility of placing the internship? Will it still be government, or now it will be based on
yes, internship is
the students?
The placement is a mandate of the Ministry of Health, and it will ensure that these interns are placed based on slots available at the training institutions and with transparency, like it is. So it's not going to change because they don't decide where they will undertake their internship. Still, you are deployed by the Ministry of Health.
And this yes. is really to seek understanding. If they decided to go to the universities of choice to acquire their degrees in medicine, why not then give them the liberty to then also decide where they will go for their internship?
That's why
because at the end of the day,
yes.
Ainebiona, the reality of the matter is that as the ministry, you're overwhelmed with the workforce that is being, or the students that are being churned out by the many medical entities that you do have across the country. Now, this does not remedy that in any way.
What I want to explain is that medical internship is mandatory. It is structured and supervised period of workplace-based training required for professional registration and licensure. So before you can fully practice to be a medical, to allowed to touch patients, you must be registered by a respective professional council, and you have to be having a license, and that is going to be incorporated such that when you finish and leave after graduation, you're ready to hit the market without having these delays that we are waiting for internships, so it's all the list is full. You'll be able to walk away from the institution of learning ready to practice with no delay, because there have been a lot of delays. Uncoordinated time frames. You say the resources are not available, we can only take in this number, but this time the numbers that leave university will be able to be registered, licensed, and ready to practice, because you'd have done your internship pre-graduation.
And so who's then intended to bear the cost that comes with internship in this?
The challenge is that we decided to debate something that has not been officially communicated. And we have to wait for the official communication that will be able to clearly provide the detail with clarity. And that time will come.
All right. Dr.
Yes.
Simwe?
My blood is boiling, so help me God. Mr. Ainebiona, this thing was prepared shambolically, and you need help, and help is available. This is what they're trying to do. Of course, they're trying to dodge the cost.
Yeah, it's all about...
But also they're trying to copy and paste. I've traveled widely on the African continent, on the European continent, in the Americas, in the Asian continent. I know the different models. And I'm not saying this that I'm a unique individual. I'm sure you people in the ministry have traveled. But I've also been an intern, and I've trained interns. This is what you're trying to copy and paste. In other countries, you see our doctor-patient ratio right now stands at 1 doctor to 25,000. And unfortunately, part of that is because there are people sitting on Katebe. If only the people who finished can be absorbed, that rate in just a snap of a finger would drop probably 1 to 10,000. So the system you are trying to copy is in systems which are already saturated. You are assuming we are saturated, but not knowing you are just using a spoon to measure your saturation. And that spoon is supposed to fill a sino track with sand. You need HTO, you need a bulldozer to fill.
So on that note, doctor,
let me just finish this point. In the systems where they're already saturated, doctor-patient ratio is 1 to 2,000, and they are trying to find a way of delaying these people coming to the system. They don't need medical officers in that system. So when you finish, they capture you. You do your internship, they don't license you. And even after you finish your internship, they enroll you into a specialized system process. People touch patients after 13 years. Go to Canada. That's what they do. That's what you're trying to copy. But what is the doctor-patient ratio of Canada? We want our doctors as soon as they come out. Let me quickly talk to the standardization. That does not remedy standardization of training or quality of training. One, regulate the entry points across all the universities.
And it's part of the policy.
Yes, but what does the policy?
Yes, and I said the policy.
Okay, let me finish.
Yeah.
Secondly, let National Council of Higher Education get decentralized. There is a university in every corner of the country now. We cannot have a National Council of Higher Education sitting in Kampala. Have one in the west, have one in the west, so that they do unannounced impromptu checks on these universities. How many students have you admitted? They must put a limit on how many you must admit. But that should not be anecdotal. It should not depend on feelings. It should not depend on whether you like the owner of University X and not the one of University Y. It should depend on your capacity. How many lecturers, how many lecture rooms, how many laboratories, how many hospitals for your students to practice. That's how you ensure quality. Then I must quickly add, if you want, let the 5th year exam be a national exam. So that I can drop the names. So that Makere does the same exam with Kabale, the same exam with Busitema, same exam with KIU, same exam with KCU. Once you do that, you have standardized training, and if someone fails that exam, they have failed the standards. But me as a supervisor of interns, I must have someone who has been qualified and released by the university and bears the title of DR, doctor. They must be, because that is the precondition for provisional licensure.
Okay.
I need someone who is licensed to say that, start that operation, when you finish, call me. Otherwise, I cannot do that with a student.
But in this arrangement, you cannot allow the person to touch the patient.
Then me, I'll be the one seeing my patients.
Yeah.
And the issue of interns seeing 70% of the patients, maybe we talked about that, is not an accident. That is how we train them. That's how we give them the hands-on.
We in all of this, there's the patient to talk
Absolutely.
about. Dr. Shamim, let's talk about the patient, because it's the patient now who will be having delayed service delivery simply because of the gaps that could already existing, and then what this could also bring in as an extended gap.
First, I think it's important that we do admit that to think that the Ministry of Health is saying that they're bringing this policy because they want to ensure competence, they don't want to have differences between who has been trained in this university and the other university. It's important that we note that the National Council for Higher Education accredits these universities to teach these particular courses. So meaning if a university has been accredited to teach a particular degree, then they do have what it takes to train these people that they're receiving to come out with a competence that is required. And we have seen for a long time these standards deteriorating. We have seen them being broken to fit into particular needs and for particular universities to have these students. And that is why we are where we are today. And even before I joined Makere, I knew that our universities are given quotas that you must admit this number of students. So when the students get into first year, I expect Ministry of Health to know that as of 2025, Makere admitted 100, KIU admitted 50, Gulu admitted 30, and these students, you follow them up until they get to their 5th year. Ministry of Health should be in position to know that in 2025, across the board, in all the 14 training institutions that we have, we admitted about 1,400, and they expect that number of interns or even less, because it can't go above that, because for most of them, maybe they have not been able to graduate, they have not been able to finish. So for me, I think it's Ministry of Health that is being lazy. They do not want to take the responsibility to follow up the training of their future professionals. Because particularly, for example, I'll tell you, for example, PSU, Pharmaceutical Society of Uganda, they follow up on the students that register to study pharmacy right from their first year. And by the time they make it to 5th year, they know that this is the number that we expect. So we'd expect Ministry of Health to be in touch with the MDPC, to be in touch with PSU, to be in touch with, the other professionals that do training and are going to be medical professionals, and budget for them before they actually
You've not talked about the patient.
So now coming to the patients, coming to the patients then, as I conclude, we must appreciate that we have staffing gaps. Even as of today, we still have them. But then also that it goes back to the point that we have been talking about, that when you take these people to the wards, when they are still being regarded as students, you do not have the trust of the patients first and foremost. But even you as the person that is training and supervising them, you're not sure if they have actually qualified to come and practice. Because the only assurance you have to allow them practice or even touch the patient is when they have been awarded the degree, they have been awarded the certificate to go and practice, which is what now is being blocked from actually happening.
Dr. Asimwe, this will be confusing because all of you will be in white coats. The patient will not know the trainee from the doctor. As long as we are seeing all of you in white coats, for us, you're all medical workers. How will that be sorted out from your side as the association?
It's crazy. Let me give you the insights. Like I've said, when a medical student is clerking, we disregard. It's for the academic purposes. Has he touched this? Sometimes they can even go a bit beyond the current case. But when an intern is clerking, it is focused because he's taking on responsibility. When I am a urologist in Mulago, my outpatient is about 40 patients. I send my interns and my SHOs to run that clinic. And that is intentional. It's not absenteeism, it's not presenteeism. If I sit and see the patients, when will they learn? We'll get to that. So I send them because they bear the title DR. Whichever university they went to, they satisfied the requirements. If you don't let that hoop be jumped first and foremost, okay, you are causing problems. Now the ministry is going to cause problems because that is going to be kept a secret. That out of the 50 students, we don't know whether you have passed. Just continue. We will see that internship. No, let's be clear. These have passed. And let there be the public trust is when people graduate. We call the village. Okay? That's the first public trust. At least your family knows you've graduated, you're a doctor. At least your villagers know. Even your former girlfriend knows that you are now a doctor. Then even Uganda Medical Dental Practitioners Council has got a document to look at and say, this degree is from where? This, but in your certificates to look at. So if the documents for the doctors are still being kept secret because they don't want them to know, what is UMDPC going to scrutinize to base on to license? Okay. So ministry is bringing us ungraduated, unlicensed medical students. For long we have been accused, as who teach, that we are unleashing students on patients. Now it's going to be for real, for real.
All right. As we close this part of the spectrum on the health sector, Ainebiona, or key things just to help in guiding where this policy is coming from and where it's going. One of them is where was the benchmarking done, or how was the benchmarking done? Two, in terms of consultations with other stakeholders, where are you standing on that one?
This development of the National Education and Training for Health Policy 2025 has been under consultation for a number of years. Even when we had issues with delayed deployment, this was the ideal solution. All the issues my sister Shamim has talked about are to be addressed by this policy. We will be able to know who has joined which university and when we expect them to do
And the consultations
internship.
were done with
and
which stakeholders?
The Uganda Medical Association. This is a new regime. Is a new regime. The previous presidents were consulted and agreed to this policy, and now the new regime is going to formally receive a communication. So I cannot determine whether they agree or disagree. That is up to them. But are we doing internship is mandatory? It's going to be binding for precondition for graduation for all professional and registration of health professionals, licensure and registration. MOH is the central authority in placement of these interns in all the health professional fields. Internship centers will be formally designated, and they must be accredited to meet the needs to ensure that the products that are trained there have supervisors, because you can be there when Dr. Astimni is busy, has not seen you as an intern. So we want to ensure that whoever goes to an internship training center has been supervised and they have met all the competencies.
So I don't hear this policy actually addressing the issue at entry into higher levels.
That's why it's being done by... It's between the Ministry of Health and Education, who are the responsible authorities, and that's why it is joint. If you've seen the page, I think that is being circulated, it's been signed by both the Minister of Health and the Minister of Education and Sports, because this we are now unified. We are moving as the two responsible entities. Okay. So we'll be able to own the student up to professional licensure and registration, and they will be ready and will be confident that so and so, once they have gone out of this system, they will be able to deliver a safe, will be able to deliver patients who are safe, and they will be able to give the right interventions when a patient comes.
Okay. Yes. On that note, government crackdown on absenteeism for health workers who fail to report to duty and show low productivity could be dismissed. When it comes to that absenteeism, it's a serious problem across the country right now. But one of the reasons why it's a serious problem is because of the multitasking that some of the health practitioners have to do here and there. Critics are saying that they are juggling multiple jobs simply because of public sector pay that is low, and because these other gaps are not being fed very well. And so as a disciplinary problem, is it a disciplinary problem or is it a symptom of deeper systemic issues that you're trying to address?
We are trying to address systemic challenges, and these included low pay, which has since been enhanced. The health workers are now among the highly paid civil servants in the country. But even with that, we have not seen really proper improvement in the output. So now we have even gone into ensuring that we digitize the health system such that we are able to know if a senior consultant, for instance, at Morago, how many patients have they seen, how many, everything is documented. If a patient needed a consultant, was this consultant there on time? And that feeds into the client charter and also the service standards that we recently launched this week. We want to know if a patient comes to a facility, the timelines, have they been attended on time? Have they been seen by the consultant or the health worker who was supposed to be on duty? Were they given the right laid down interventions as stated in our service delivery standards? Because sometimes you find we are getting, we go to make an assessment, you find a senior consultant who is supposed to be there for a number of days has not been there, has been in a private facility. And those are the realities we are dealing with.
Dr.
Yet they are taking a paycheck at the end of the month.
Is it fair for government to enforce stricter discipline when the working environment itself may be part of the problem? There's absenteeism of the medical person. There's absenteeism of equipment. There's absenteeism of medicines.
All right, thank you. But since now I have the mic, I just beg to just ask a question. If that document is not yet either available, if it's not yet done, can you allow some people to have a look? Uganda Medical Association, the person I took over from gave me a huge file, and that is not one of them that he gave to me. People in other sectors, I will not speak for them, we've talked quietly. Most of them are our colleagues. We started with them. Some of them were ahead of them. So we know them. They were not consulted. But that's for another day. Is there a gap where we can make an input? Because you cannot fight government. Once government says A, it will be A. Now that we are moving in that direction, which is the right direction from the broad picture, can you invite us to at least, not on the news media like this, to make an input? Enforcement of discipline, very good step in the right direction. And that needs to be done. But from the word go, can we make an input, please? Otherwise, it will also be dead on arrival, I can assure you.
Okay. It
will be dead on arrival. Let me give you my proposal that I have. And I am begging His Excellency to call me, because I've got a very beautiful proposal. This is called, yes. And if he invited me, I presented this in 2017. This is called command and control. This is senior supervising junior. And that attachment, which is a mentorship, is for a professional lifetime, where a senior consultant supervises 3 consultants.
Okay.
And each consultant supervises 3 juniors, and this is a lifelong, and they don't have to be in the same space. If you give us the Uganda Medical Association to police ourselves alongside your policing, we're going to have it beautiful. Otherwise, you're going to put in the books, we'll write in them, you're going to put in the thumbprints, something can be done to those thumbprints, and you'll achieve nothing.
Traceability. Okay,
if you're not involved in that discussion.
Let me give the closing voice to Shamim.
Yes, I do appreciate that that is a good step in the right direction. It is important that we address the issue of absenteeism. It's important that we address the issue of, clients not getting, or patients not getting the services that they're meant to get. But then also it's important that we address why, for example, we've been having this absenteeism. We have on several occasions seen, first and foremost, patients complaining that they go to hospitals and they don't even have beds where they're supposed to be attended to. We have seen most of them going, and doctors do not even have gloves. They do not have basic equipment for them to start to do their work. We have seen where there is no medicines at all. So when you want to address the issue of absenteeism, also address the issue of equipment, address the issue of the environment in which these particular practitioners are working.
The closing voice from the Ministry of Health.
What I can say, there is a lot of investment the Ministry of Health is doing to ensure that the work environment is up to standards, to ensure that the medical doctors we employ have the right tools to use. They have everything that they require, but currently working within the available resources. And the resources, I can say, will be able to ensure that our clients get the high quality of care they deserve. And that's why we have this national education and training policy. We have the standards of service, the service delivery standards. We have the patient's charter. And each and every health facility is going to develop their patient's charter, their client's charter. And this will prescribe what the clients should expect, and each institution will meet their side of the bargain.
Do we have a doctor's rights?
Hopefully the client will allow me. One of the truth does remain clear. Behind every policy and debate, there are millions of Ugandans whose lives depend on the strengthening of the health system of Uganda. So the real test is not to be about the policy announcements, but whether these policies actually do hold water and they are sustainable right from the beginning, and all the other complementary tools in order to facilitate their purpose are actually put in place. That brings us to the end of this conversation. I am Priscilla Regina Naluoga.